Greetings, dear colleagues. Today, I would like to share with you some small tools that we have. These are the brief interventions and some of the motivational counseling techniques for people with alcohol addiction. And after the presentation, I plan to discuss that we can discuss to which extent these tools may be used for military servicemen. So let us start. So we have different options of psychosocial support for people with alcohol addiction. If we look at the WHO pyramid for the optimal organization of services, in the bottom we have the mutual aid groups, then we have brief interventions, motivational counseling, cognitive behavioral therapy, and rehabilitation programs. As for the pharmaceuticals therapy, most often we have the NICE protocol and other clinical guidelines. Most often we treat the withdrawal syndrome or detoxification and treatment for hypovitaminosis of B1. Also, the protocols include sensitizing therapy and most often like disulfam and drugs that reduce the positive effects of alcohol. Naltrexone. As for the acamprosat, it is not yet registered as the means of alcohol addiction treatment, but naltrexone may be used. And of course, we have treatment for insomnia, depression, and other psychiatric disorder. This may also be regarded as psychotherapy. Next slide. I allowed myself to make this slide about the non-evidentiary methods of treatment, which are very widespread. And earlier, when I used to work as a doctor, people were calling me and asking me if I was treating alcohol addiction, if I was able to encode people against the alcoholism, and I said no. And they asked me they say that I have to treat. So we have the Dovzhenko's method, torpedoing, stitching, or rolling eggs. All these methods are very widespread still, but they are not evidentiary based. This is just the general framework before we start discussing the brief interventions. Next slide, please. So, the brief intervention is not a separate method. It is a set of different interventions. Unlike psychotherapy, it is limited in time, which can be spent on using the methods. It can take from a 5-minute counseling session up to 2-3 sessions. Every session would take 45 to 50 minutes. But usually one session takes less than 20 minutes, and it also has 2 or 3 follow-up contacts in the future. Next slide, please. So what is a brief intervention? It is a brief, focused, non-confrontational, personalized conversation with a person about their problems related to alcohol, drugs, or gambling. This conversation may be about any problem or all the problems at once. The goal of a brief intervention is to help the person think about their behavior and to help them understand the connection between what they are doing and the consequences related to their behavior of abuse, gambling, and abusing alcohol. At the same time, brief interventions are not intended to treat people who are already addicted. They are more used to increase their motivation to refer for a more intensive treatment, if we are talking about the addicted people. Next slide, please. They can be used in different institutions. Usually these are the primary care centers, hospitals, outpatient clinics, polyclinics, and in the emergency institutions. These interventions can be provided by social workers, nurses, general practitioners, and other medical professionals. Next slide. We have three main forms of brief interventions. Well, we have a lot of them, but these groups are the most frequent. The flags, frames, and 5A. As for the frames format and 5A, I will tell you a little bit more about those. Next slide. Brief intervention is usually carried out after the screening procedure has been performed. The screening helps to determine the level of intervention that is necessary and what things would be the most beneficial to the person, and which professionals the person should be referred to. Next slide. So these are the screening tools. We have a lot of those. And the WHO most recommends the audit and assist. The audit is for alcohol abuse, and the assist covers the alcohol, cannabis, and other drugs. Next slide, please. A few words about audit. Well, this test is to identify the alcohol use disorders. It includes 10 questions. So the first one is, how often do you use alcohol? How many shots of alcohol do you use every day? How often do you use 6 shots per one take? How often did you notice in the previous year that you are not able to stop drinking? And on the next slide, we have the following 5 questions. They are about how often did you need to use alcohol in the morning? How often do you feel guilty or blame yourself for drinking alcohol? How often you were not able to remember previous events? Did it happen that anyone else has been injured because of your alcohol consumption? So these 10 questions help identify the problems the person may have with alcohol. Next slide, please. Thank you. This is about the meaning of the plans, what interventions are needed, and the levels of risk. So we have materials about the use of interventions for alcohol. They are translated into Ukrainian language, and they are posted on the website on the Public Health Center. So the guidelines on interventions has been translated and published. Also, it is planned to translate the textbook with the trainings on this intervention. So the first level from 0 to, so when the person scores from 0 to 7, these are people who use alcohol very little, and sometimes the interventions in this case are not very necessary except for awareness raising. And from 8 to 15, if the person scores 8 to 15, it is recommended to give some simple pieces of advice. From 16 to 19 points, simple advice is recommended as well as monitoring and brief counseling, and over 20 points means that the person has to be referred for professional diagnosis and treatment. Next slide, please. Then we have this frames approach. So this is the feedback. Provide feedback on the screening results, highlight potential risks or the level of current harm. For example, as a result of audit, if you score 19 points as a result of audit, this is on the threshold level between when you
That's bordering what you can, how can I make it properly? Where you can, when you can actually spot the addiction and and where you have health hazards. And we can talk about the hazards in depth. Responsibility, it's about responsibility for the patient's choice. Obviously, it's your choice to consume or not to consume, and whether to change your behavior of that. Advice is providing advice on what can be done further, and consulting for nurturing the positive change. And we can talk about whether like what could help with stopping the alcohol use, what are the consequences for the health of the patient, what can be the benefits, and how we can actually do it. Menu is a very interesting point where you can provide not just one recommendation on what to do, but like for example, according to your issue, you can provide a spectrum of strategies on what can a person do. So you can consult you can consult Alcoholics Anonymous. You can undergo treatment in private institutions, or for example, try sociotherapy or narcology clinic, or you can try to get over that yourself, get a goal for yourself not to drink anymore, and you can plan this this model of not using alcohol on your own. And additionally, next element of the frames approach is empathy. That's when you show empathy for the patient's thoughts and feelings, where you understand that that's that's understanding the general behavior is hard, especially when it's the only joy of a person and the only way to relax. Perhaps we can we can talk about self-efficacy. That obviously we can talk about the just getting the person to believe that they can do it on their own, but people might understand that it's the problem, and they get over that quickly, and they do not abuse alcohol, and they change their quality of life. It's just the basic frames approach, which is quite simple, but it is also quite effective because you do not enforce the patient to do something. You offer just offer a range of options where this person can receive treatment and what would be the result of that. And one more thing, not every client needs it, but in this menu stage, you can you can say that you can continue abusing the alcohol and die, but not all patients need to hear that. Not everybody can understand this adequately. So 5A, it's a slightly different approach. It's still easy after after you have decided to conduct this intervention with your patient or your client. You can ask you can ask about alcohol use. You can evaluate you can assess whether the patient's alcohol use meets the criteria for the diagnosis of abuse advice. That's where you issue advice on what can help the patient to stop or reduce the use of alcohol. You can also assist with the client or patient's readiness to change according to different stages, and you can offer uh, different help, different types of help, which might be useful on that stage, and arrange for additional follow-up contacts with the client or patient if there is a need to do so. As I've said, institutions. Next slide, please. Thank you. The institutions where we might have brief interventions, for example, offices of primary care physicians, it can they can be conducted by a doctor or a nurse. And right now, where we have match gap training for the doctors who, for doctors and nurses that are being informed on how to conduct the audit screening and how to conduct brief interventions. We can also use the emergency department for that, special trauma and toxicology departments, detoxification centers, or just patrol or guard service of like in many countries, the police personnel are trained in the field of brief interventions. Yeah, we're just going through this real fast, but I wanted to just highlight the tool of brief interventions. I will highlight that the translation of the brief interventions manual is available on the website of Center of Public Health. I will try to find it later and send the link to the chat. Next slide, please. And also, we'll quickly talk about motivational counseling. I have this wish to combine these two topics for the audience so that they would understand the difference between those tools, as well as how you can use them in order to talk about that during the second part of our work. So motivational counseling. It is also one of the uh, proven methods of treatment for people who suffer from alcohol use. And this is more of a client-centered style. So it's present in the domain of client-centered therapy, and it allows people to study their ambivalence towards drug abuse or alcohol abuse, and they can start changing their behavior. Next slide. The the traditional approach uh, of enforcing the change, it was built on the simple notion that if you fine a person or you provide some other penalty or you will destroy their dignity, that it would be more probable that that this person would follow your advice, your order, so to say. And this is more of a directional leadership of over clients or patients or loved ones. It's pretty widespread. It's always widespread, and uh, and the traditional approach is based on the notion that change is motivated by discomfort. And even like we have a saying, like there was a saying, uh, that the patient should crawl on their knees. That's when we're going to have some results. And in order for people to change, they need to feel this maximum discomfort. And while they do not receive this kick in the butt, they like only when they receive this kick in the butt, they would change. So people don't change if they haven't suffered enough. And this approach is still present in many spheres. One more approach is motivational. Motivating. Next slide, thank you. Motivating is based on the notion that a person is actually knowledgeable and they understand that. Okay, question to those who smoke. You know that smoking is actually bad for you? So, do the smokers here know that? So, the motivational approach is based on the notion that the person already knows that it's bad, but the person is ambivalent about whether to quit or not to quit, to stop using or not to stop using. And we know that change is hard. Next slide. And we know that ambivalence is, if we're not talking about schizophrenia here, is more about experiencing conflicting feelings about something. What do you have some moments where you like something and you hate it at the same time? Have you ever had those? When you so when you really want it, but mom doesn't allow you to. So there are a lot of people that are ambivalent towards change, and and th- and this ambivalence is the key element of motivational consulting. We understand that the person is ambivalent. Next slide. And also in motivational consulting, we have this idea that people do not change because they don't want to, Well, like that they have this idea of denial, of that they're not unaware or careless. Like the idea is that the use itself is a disorder which disrupts the normal functioning of the brain, and what's being disrupted are the brain areas that are responsible for motivation, attention, memory, planning, and that's one of the issues. Yeah. If we're citing the classic out here in the chat, we'll talk about it later. And next slide. In motivational consulting, counseling, I'm sorry, we have this idea of the stageness of attitude to change, the stages of preparedness towards change. And Prohaski and De Clemente that studied the patients studying from tobacco abuse that have stopped smoking, and they've done the study in 2000s, that they've found out that there are some stages of readiness towards change. There we have the stage of pre-contemplation, contemplation, determination, the action stage, and the maintenance stage. Next slide. The stage of pre-contemplation, and we sometimes call it denying. That's when the person is unaware of the problems associated with alcohol use, and they ignore comments of everybody else that they are doing something harmful. And if you continue using alcohol, that maybe you are still at the stage of pre-contemplation.
The next stage is contemplation or reflection. At this stage, people are ambivalent. On the one hand, the alcohol brings them joy, but there are some negative consequences, and they think, well, they are not sure if they have this problem or not, to drink or not to drink, to wash or not to wash. So this stage may be very long, in spite of the fact that the person may understand that they have a problem. They are not taking any decisions. Next slide, please. The next stage is decision-making or preparation. At this stage, people are ready to change their behavior. They believe that the harm outweighs the benefits, and they believe that the changes are necessary. And maybe a lot of you tried to study English language or jog in the morning, and you made this decision that I'm going to jog in the morning. But it's not a fact that this really happened. Did you have this experience? Can you share? Yes, this happens every day. Yes. So, yes. Jogging and learning English. So, the person may have a decision, they understand the situation, and they are sure about it. Or what about stopping to eat sweets or candies? Mark Twain said that he stopped smoking 50 times a day. So a person may have made the decision, they are ready to stop the abuse, but it's not happening. And this stage may take a long time. Maybe you have planned to move somewhere else, to some other place. Maybe you have prepared everything. Of course, it's clear that a lot of people are not located in Ukraine and they moved not because of a good life, but sometimes you have to contemplate for a long time. You have to dare do something. For example, if you want to change your job, you no longer want to go to your usual work. Next slide. But you are used to this work. So number 4 is the stage when the person takes action, not when just make a decision or wants to do something. So at the stage of preparation, a person may buy a sports costume and the new sneakers, but they go out in the morning and see that it's raining, so they go back to bed to sleep. So at the stage of action, the person may start visiting the group of anonymous alcoholics. They throw out the pack of cigarettes and doesn't buy a new one. So at this stage, a person may take some real steps in order to get some strategies to maintain the behavior. If you are trying to stop using sweets or candies,
Нічого.
what could help you?
Не знаю.
No, nothing.
Насправді
Nothing could help.
допомагав спорт. Ти розумієш, що нічого не
In
можна
fact,
зробити, бо дуже багато
sometimes
солодкого.
sports
Ти думаєш,
helps
на що вони потрібно було.
when you eat too much sweets and then you think, what do you need them for? Volodymyr suggests to use all other sweets. The next slide, please. And the stage number 5, this is when a person maintains the changes, when people stop abusing alcohol or something else, for example, for 3 months, but they need to make efforts to keep the withdrawal. They need to work on their emotional problems, to work on their circle of surroundings. Next slide, please. And then we have a relapse. This is not a mandatory stage, thanks to God. It may happen or it may not, but sometimes clients have to pass through this stage. And when we work with the patients or clients, it's very important to discuss with them what they can do if relapse happens. That the alcoholism or drug addiction are chronic conditions and they may have relapses. It's very important to understand that if a person is very well oriented for recovery, a relapse will not be a problem, and that they may continue maintaining their sobriety. The same goes with the sweet things and candies. It is important not to relapse every day. Next slide, please. And in order to help a person to progress from one stage to the next one, so it is impossible for a person who ignores abusing alcohol, or, for example, if the person ignores the problems that occur because of gambling or smoking, they can't just jump to the action stage. Sometimes this may happen because of some external events, because of a disease, or maybe because of pregnancy. Girls usually stop smoking when they get pregnant. But it's not always easy. So at every stage, there are certain tools that may help a person to progress to the next stage. So on the stage of contemplation, when the person is hovering on the decision whether they should study English or not, whether to go jogging in the morning or not, at this point it is important to ask this person some questions to help them understand their motivation. So, for example, what are the reasons that make you want to go running in the morning? What changes specifically would you like to see in your life so that they would help you stop smoking or abusing sweets? Well, I'm sort of going against the sweets and candies. Maybe I should go against cookies. Yes, the sweets are good. Your pieces of advice would be useful for us. So how will this change your future? Why these changes, for example, jogging in the morning or doing sports or yoga, why they are important to you? In case of alcohol abuse, how can alcohol limit you in your life? So the changes are not only about stopping smoking or running. For example, they say, I would like to go to a conference abroad and I need to know English. Or I would like to have a great posture for the next summer. I need to eat less or something else. Or, for example, I would like to restore connection with my family, to improve my relations with the children, and how alcohol may become an obstacle on the path. Of course, we can have some analysis, pros and cons, short and long-term consequences of different paths. We have the card squares. We have a lot of tools. Next slide, please. I would like to say a few words about this tool. It sounds like oars, but it's more about rows or rowing. This is the word. These skills help motivate a patient or client to have a conversation, to explore their ambivalence about drinking or drugs abuse, and to clarify their motives of the things that can help them to reduce or stop using alcohol. So OR is an acronym. It means open-ended questions, affirmation, reflective listening, and summarizing. Next slide, please. So, open-ended questions. Very often it happens, well, I'm not doing any trainings for 4 years, but when I did, I was trying to explain the open-ended questions, and all the counselors and psychologists said, Yes, we always put open-ended questions. But when we started practicing the skills, it turned out that 70% of their questions were not open-ended. So it's very important to to look after one's to to be attentive. For example, if you ask a question, do you suffer from using alcohol? The person may say, no, I like it, I'm not suffering. But when you ask a question, what do you think about abusing alcohol? Or would you like to stop using it? This question are also closed. But it's better to ask a question, what would be the biggest reason for you to stop abusing alcohol? So you can use different open-ended questions. For example, there is a list of the main questions that journalists use. What, how, when, where, and why. Usually it is very difficult to answer to the why question. It is not recommended. But if you ask the questions what, where, how, and when, it is very important to ask your client those questions instead of giving the recommendations or asking closed questions. So we have this. Joke from one of our stand-up comics. You don't have next slide. You don't have any newspapers, right? Right. So it's very useful to give hints to the answers. So next one is affirmation. This is supporting the patient's ability and positive feedback. In general, when you speak to your client, it is very important to support them. Just because they started discussion their problems with alcohol with you. And it is important to remember that the final decision will be taken by the client. So it makes no sense to push the client. And we need to approve even the intentions. And if we compare them with somebody, we should compare them not with other patients, but with their behavior in the past.
And by doing this, we support the person, but because they start to talk about it and they started answering our questions and they start to they try to do something. Next slide, please. For example, I am grateful that you are willing to tell me about your problem, and it's really hard to talk about it, and I appreciate the fact that you continue to talk about it, and other different supporting sayings, affirmations. Next slide. Reflective listening, active listening, and reflexive repetition. It's very essential to use the usual instruments of active listening, like nodding, open pose, like everything is essential, but it's also essential to repeat the last words of the client or patient in order to encourage them to continue the conversation. Or for example, you told me that you feel very tired and you want to drink something, and whether I understood you correctly. And sometimes repeating key words can guide them to the narrative that you need. It's very essential to understand what you want to focus the conversation on, using the keywords of the client. For example, and then the driver looked at me inappropriately and I got angry. It reminded me of my last place of deployment where I had a lot of misunderstandings. Why do they always pick on me? And you can repeat, you can repeat the parts, look at me inappropriately, and that would be one direction, one path of the conversations. Got angry, that's more about emotions, of emotional regulation, and how to use it. The last place of deployment would be about circumstances of being in the military, what happened there, a lot of misunderstandings. We're going to be talking about the types of misunderstanding, and picking on you, it's going to be a different story. So it is about, like, what I want to say, that even like this easy tool of repeating keywords could have a big impact on the overall conversation. And next slide, summary or summing up or generalizing. When you sum up those key moments of your conversation and you suggest the thoughts about the next steps in order to evade the conclusions that were not present in the discussions, but you had key moments, you had questions, actions which were there, and then, for example, uh, did I understand you correctly? That the result. The migraine appeared after your concussion, and it increases after weather changes or alcohol abuse. And the client starts thinking, and you might say whether you want to stop or quit drinking alcohol entirely, and then the client verifies whether you are right or wrong. And that is the basic technique. You might try practicing this technique on your loved ones, asking open-ended questions. Can you do it? To use the active listening technique and summing up, if we're talking about every process, about changes that the person would like to have. For example, about purchase of something, of some small thing, or some more complicated issues. So that to try to practice whether you can actually do it. Of course, it is. Of course, we have discussed motivational consulting too fast. Usually, the brief interventions training can last for a couple of days. And the practical part of motivational consulting training can last for 1 or 2 or 3. Yeah, Volodya asks, what type of candy do we not buy? I do not know. And next slide. That's where In the presentation, you're going to have some additional resources. We have resources on motivational counseling. We have some resources on for example, Venida on different tools. Samsha also has a tool, and we have the UNODC TreatNet. We have psychosocial interventions and cognitive behavioral therapy and motivational consulting. And also, I've told you about the Center of Public Health website, where we have the translation of the manual on brief interventions. And next slide. I asked, like, you sent me the questions, but I would actually like it more to talk about the tools for military personnel. How can they be used for working with them? Who can use them? Whether it's possible to use them. And if you work with military personnel, what do you use and what can you use? And where do you refer military personnel for help? And I suggest we stop recording and move on with our discussion. Thank you.